one that I will call electricity in the heart. Okay, it's the case of a 70-year-old male who has been diagnosed with dilated cardiomyopathy for many, many years. So this is a diagnosis that has been known, and now she is developing progressive dyspnea. Okay, so let's take a look at the echo. Okay, let me switch to the next patient. Okay. Okay, let's start with this echo here. 4-chamber view. I'm sure that most of you will already be able to make the diagnosis just by one short, quick look at the 4-chamber view. Because in essence, what we have here, we have a very strange motion of the heart, and we have a very strange motion of the septum. Okay? I mean, what is left ventricular function in this patient? To be honest, one cannot really say, because different parts of the myocardium are contracting at different moments. So how do we define end diastole, and how do we define end systole? In essence, this is something that is not really possible in patients with this pathology. And what is the pathology? Does anybody know? Oliver, are we getting any answers here? Okay. Panagiotis says it's the synchrony. There are some people who think it's septal dyskinesia. Well, Panagiotis is completely right. This is the synchrony. And the answer is maybe not even in the image. Here, it's in the ECG down here. If you take a look at this, you see that this is a very, very broad QRS complex. So this is some form of bundle branch block, probably most likely left bundle branch block. And this is the problem we have in this patient. This is a case where abnormal conduction causes the synchronous motion of the myocardium. And let me go back now to, or let me go let me show you some other views. Okay, this is the 2-chamber view, and you see that it's not as prominent in the 2-chamber view because here we are comparing, oops, the anterior wall and the posterior wall. It's more easily visible in an apical long axis view where we can compare the posterior lateral and septal wall. So the synchrony is usually an abnormal septal motion compared to the rest of the myocardium. And one other thing that you can see in this patient is that there is even spontaneous contrast in the left ventricle here. You see this, the smoke? Okay, so in essence, this patient must have hemodynamic problems. And what has happened? Well, he has, or she has, dilated cardiomyopathy, and dilated cardiomyopathy increases the risk for developing left bundle branch block. So approximately 30% of patients who have cardiomyopathy also have a bundle branch block. And this bundle branch block is not good for the heart. It causes the heart to contract the synchronous, obviously, and this is very inefficient for myocardial mechanics, which means that it puts an additional stress burden on the ventricle, which in turn leads to further deterioration of left ventricular function. So this is again a vicious cycle, and this vicious cycle must be somehow stopped, and there is a treatment for that. I'm sure many of you are aware of the form of treatment that we can give these patients, and the form of treatment that I'm thinking of is called, does anybody know? Let me see who gave the right answer first. Okay, Anna says it's CRT. Well, correct. You need to perform CRT in these patients, which is a special pacemaker therapy where you implant a lead in the right ventricle, right? And then you place a second lead in the coronary sinus. And this lead in the coronary sinus, which kind of runs around here, stimulates the ventricle from the lateral wall and the other right ventricular lead from the septum. So you can kind of bypass this conduction abnormality and perform what we call resynchronization. Okay, now there's been a big issue of the role of echo in patients with the synchrony, and are we actually able to detect the patients who really need CRT therapy or not? And the problem was that many people that got this CRT system, which is fairly expensive, did not benefit at all. And so there, the thought was that, okay, there is a number of so-called non-responders, somewhere in the range of 30%, and maybe echo is able to really delineate which patients benefit and which don't. And the issue was that a lot of different parameters have been tested and looked at, and the studies have actually shown that echo does not really help in determining which patients are candidates and which are not. And this is my take on this. I don't think these studies were really designed to show how good really echo is. I think the most important thing that you have to look at when you see these patients is just the way the septum moves. I think that if you are trained, it's very easy to detect the synchrony. And I'm sure that all of you will realize that this is a desynchronous motion. Once you've seen it, you will always remember how a desynchronous motion looks. And to add to the visual impression, you can use two very simple measurements. And I'll show you these measurements, and they should really help you in your clinical practice. This is the first measurement that I'm going to perform, where you place a pulse wave Doppler signal as a sample volume right in the pulmonary artery. Right here is the pulmonary artery, and this is the spectrum you get. And then you measure what we call the electromechanical delay. What does that mean? Electric is ECG, and mechanical is blood flow. So you compare the distance between, or you measure the distance between the begin of the QRS complex and the begin of outflow. Okay, so from here to here, this is what you measure. Then you get a time interval of 170 milliseconds. Now this is for the right heart. Okay, remember this. We're going to put this in your head, 170 milliseconds. And then you do the same thing for the ventricle. Let me see where it is. Here we go. Now this is the same thing in the 4-chamber view. Now we look at the measurement across the aorta. This is a continuous wave. I think this is better here. Okay, this is a pulsed wave now in the LVOT. And again, we measure the distance from begin of the QRS complex to the begin of outflow. Okay, and then we get a measurement of 188 milliseconds. This, what you have here, is the so-called aortic electromechanical delay. And the cutoff value is 140 milliseconds. A normal patient might have maybe 80, 70, maybe 90, but certainly not more than 100. If this value exceeds 140 milliseconds, you can be quite sure that there is a significant degree of desynchrony. And if you compare this measurement to the measurement we performed before, and you subtract the two, in other words, you take 188 and subtract 100 and what was it, 17, you get something like 71 milliseconds, the difference between the two. And the cutoff value here is 40. Everything that is more than 40 speaks for desynchrony. So what do we have here? We have a patient where we clearly see that there is desynchrony, where the measurements fit quite nicely. And then we also look at the width of the QRS complex, and if it's over 150, you can be quite sure that he would be a good candidate for a CRT, and that the likelihood of him benefiting from a CRT system is very, very high. There are a few other issues which must also be taken into account, and that is the size of the ventricle. The smaller the ventricle is, the higher the likelihood is that he will recover. In other words, that there will be what we call reverse remodeling. And the thicker the myocardium is, and the less scars there are, the higher the likelihood is. In other words, patients who have coronary artery disease have less probability of recovering versus patients who have dilated cardiomyopathy. And if we look at the myocardium here, you can see that it's fairly thick. It looks a bit worse here inferior from a contractile point of view. And the ventricle is dilated, but it's not huge. So there is a low scar burden here. There's a relatively small ventricle here. We have fairly thick myocardium. So everything speaks in favor of this being someone who would significantly benefit from the procedure. So if you see this, it's a must. You must simply perform CRT, especially if the patients are symptomatic. And I'll show you what came out of CRT therapy in this patient, because it's so impressive to see what this therapy is capable of doing. Now, this is a follow-up study. What was it? I think 6 months later, I think 4 months after he got his CRT. Look at this. This is truly the same patient. You know, his function is her function is almost normal. Yeah, you have a ventricle which has a diameter of, what is it, maybe 57, so maybe mildly enlarged. And if you take a look at the motion of the heart, you see that it's almost completely synchronous. And if you measure the parameters now, let me see if I can find here. If you measure the parameters that we did previously, we compare the beginning of the QRS complex with outflow. Here we have 77 milliseconds. We've almost normalized the aortic electromechanical delay. So everything is really nice in this patient now, and he is what we would call a so-called super responder. In other words, we've almost healed the patient with the help of CRT therapy. So pretty neat thing. What is your job as an echocardiographer? Well, your job is to find these patients. We see a lot of these patients that come into our lab, and nobody's ever thought of implanting a CRT system in them. If you see them, take a look, measure the parameters I showed you, and refer them to surgery and to further evaluation for CRT. Okay, so this was this case. Okay, there's a few questions left. Ahmed asked, is there septal scarring? Well, not really. In this patient, she had dilated cardiomyopathy, and she had a normal coronary angiogram. So there was not really a scar in this patient, but you always have to watch out. In patients who have dilated cardiomyopathy, you can frequently have areas which show less or more contractile than other areas. So it's not always homogeneously reduced left ventricular function. And Maria asked, should we do TDI measurements? Well, Maria, I know this is something that has been proposed, especially at the time the big studies have been performed to test whether CRT can be, or to test if echo helps in CRT. And my clear answer is it's useless. It does not work. I think there are so many reasons why it doesn't work. First of all, it's difficult to do. In selected patients, it might work, and you can determine if the synchrony is there. But I think the value of TDI is just not very high. I know there are other people who think differently, but the community has turned away from TDI and is not performing it anymore because it's a waste of time.